public record. My name is Allie Franklin. I'm one of the managing directors here at Health Management Associates, and important for you to know, I am a 30% service-connected disabled vet, served in the U.S. Air Force, also worked at the VA and the VA Medical Center in Washington State for a period of time. And so I come at this both from a personal experience and then also from a professional experience. We're Health Management Associates, and we are a leading independent national research and consulting firm that focuses on improving the administration and delivery of public health, healthcare, and social service programs. And we've partnered with the Mississippi Department of Mental Health and its efforts to enhance the state's crisis response system by providing monthly online crisis response training, as well as convenings of the crisis system and crisis system partners. So we're really thrilled to have you here and excited about this training in particular. So our topic today is around serving those who've served. What does crisis care look like when we're supporting veterans and their families and the people who care for them? So the way we'll spend a little bit of time today is in looking at three different components. So one is addressing what are the unique aspects in caring for veterans and their families. So what are things that you need to be aware of when you're thinking about or sensitive to when you're thinking about working together with veterans and families? What are some things when we think about veterans' choice and voice? What are some things that you need to be aware of, both resources that are available, but also kind of landmines or things to avoid when we're working together with vets? Also, what are some specific resources in the Mississippi system around what is available to veterans? And then also, where are some opportunities where organizations can partner with the Veterans Administration and the VAs locally to think about enhancing the system of support for veterans here in Mississippi? And the last piece that we'll talk about are core components and best practices around supporting veterans and their families. So thinking about what are the best ways to approach things, what are some evidence-based treatments and approaches to be able to provide care so that you're best equipped to be able to support veterans that you come into contact with, whether they're in crisis or in kind of a situation that has some rising risk that's happening in the world of veterans. Why is this such an important topic? So when we look at the statistics, they really tell a pretty stark story for us. And that is that veterans are disproportionately impacted by suicide. So when we look at the rates that we have looking into at 2022, veteran suicide rates are more than double the rate of deaths by suicide in the general population. And when we think about that, so what does that average out to? And by the way, Mississippi's numbers are right in line with what the national numbers are, around 17.6 veterans dying by suicide per day in the year of 2022. And when we look at who are most at risk, we look at the folks who are in the age groups between 18 and 34, and actually 18 to 54. And when we think about what are some specific groups that we need to be particularly thinking about, those folks who are within the first 2 years post-service in that transition period are in a particularly vulnerable position because of that mix, that transition time, and thinking about how does my service translate into the civilian world, thinking about it from a job standpoint, thinking about it from a culture standpoint, and also navigating the system and figuring out how to access care and get the support that they need. It's also when we think about what is the rate of suicide among women's veterans compared to women in the population. Women veterans are at 92% higher risk than a non-woman vet, and that for male veterans, the risk for death by suicide is 60% higher among veterans than it is among the typical male population. So those are some important numbers to think about. You know, why is this important to be talking about today? And what are the kinds of things that we need to be sensitized to and thinking about as you're approaching care for vets? So we have an interactive piece today. What we are asking you to do is to write in the chat one key factor that you believe may complicate crisis response and support for veterans and their families. So if you could just take a moment and that chat, by the way, should be something along the bottom of your screen where you can find that little, looks like a little bubble and it says chat. You open that up and you can type an answer. So think about, what's one key factor that may complicate veterans crisis care? No right or wrong answers, by the way. Lack of resources, some disconnected systems, or even it could be lack of resources. It could also be not knowing about the resources. There may be resources available, but they're not sure what they are or how to access them. There can be hesitancy in reaching out. You're correct, while someone is active duty. And unfortunately, if you have that mindset or you're concerned about seeking care while active duty, that can sometimes translate over into veterans experiencing that, saying it's not safe to ask for care in the military system. Staff shortages, so access issues can come up. Yes, you guys are hitting all the right themes. Ashamed to ask for help. Some of the culture around military service can cause people to feel like they have self-stigma. Lack of resources. I see a lot of lack of resources. Oh my goodness. Okay, so for Zoom, knocking coworkers off, Rachel may be able to help you on the back. Some of that may be that you may need your own unique login versus a shared login. 988 stays in the state, but 911 when you 988 when you press 1 goes out of state. Okay, interesting point, Brenda. That is a piece. And then a fear of stigma, absolutely, as well as self-stigma, and we'll talk a little bit around that when we get to that slide. Great points. You all are spot on about what are some of the things that get in the way. So thank you, and keep them coming. If other ideas pop up, or even as we're talking about it, please feel free to keep putting things in the chat in that way. As you can see, we're going to actually be covering some of exactly those topics that you were just talking about. Uh-oh, I hit the wrong button. Now I'm seeing way too much chat and not enough. There we go. Okay, great. Thank you so much. So let's dig into it a little bit. What are some of those factors that impact veteran suicide risk? So when we look at kind of what the top ones are, homelessness, not having a safe place to live or a safe place to stay is one of the top causes for thinking about risk for suicide. We also look at history of military sexual trauma. And I want to give you some definitions around, and by the way, in the military term, we might call that MST. What is military sexual trauma? This is a term that's used by the VA to refer to any experience of sexual assault or sexual harassment that's experienced during a military service. And what that means is any sexual content which was against their will. And by the way, military sexual trauma can occur to males and females, as well as non-binary. And so that one of the things that happens with the VA is they're doing regular screening, asking the question around, have you had the experience of being approached or being asked to be involved or being required or forced to be involved in military sexual content during your service that was not consensual, that you did not agree to. And what we find is that about 1 in 3, I just want to pause there for a second, 1 in 3 women reveal that they have some form of military sexual trauma, and about 1 in 3 women and 1 in 50 men. And so it happens invisibly sometimes. It's not something that you might be able to see, whereas, someone has lost a limb, you might be able to see that immediately upon seeing them. But military sexual trauma is is a silent killer. As you can see here in this graph, that dark blue line, that dark blue solid line is looking at what is the unadjusted suicide rate for veterans. That top line are male veterans with military sexual trauma. And so while the prevalence is lower among men, it may not actually be lower because it may be that fewer men are willing to report that or to say yes on a screen, but we can see that it has a very high level of lethality and concern for risk. Whereas female veterans with military sexual trauma are also very high. And the female veterans without military sexual trauma, you can see is still an important number here. It's the lowest on the graph, but it's still of risk. Our two highest factors are male veterans, both with military sexual trauma and without. But it's a very serious issue. And so it's important for you to know that those are some of the things that are leading into this. Another thing is a behavioral patient flag in the VA treatment records. So this comes when someone has been receiving care from the Veterans Administration and has had some sort of a behavioral incident that has occurred. So whether there's been a kind of a blow up that's happened together between a kind of vet to vet, or whether that's been a vet involved with one of the staff members. Justice involvement, cancer diagnosis, and as we spoke earlier, that age group between 18 to 35 is a high-risk group. So those are important factors to keep in mind. An important issue when we're talking with vets, and by the way, in the suicide prevention world and early intervention world, access to lethal means is gaining visibility for all populations, but it has traditionally and historically been a very important thing when we're talking about this with people with a military background. And part of it is because one, it's a significant, if you take a look, firearms are a significant cause of lethality when we think about suicide risk. But another piece is that a lot of military specialties involve weapons training, and that unless you are in a non-combatant role, all military roles have some sort of training around how are you using a weapon, and do you have access to a firearm. It's a piece of the role around being in theater, around protecting the site. Even I will tell you, I was a military service officer. I was considered to be a non-combatant. It was still part of my role to have access to and training and using a handgun in case I needed to protect patients who were a part of a forward in theater military base. And so military veterans have access to training and a comfort with using firearms. And there's a National Institute of Health estimates around 45% of veterans own a firearm and have access to them. Why is that important? One of the things we'll get to in a little bit when we talk about access to lethal means is that if someone is having suicidal ideation and they're thinking about that they might want to end their life, there's a sense of ambivalence. But when they then have access to the means in which to end their life, that ambivalence can turn into a tragedy and can turn into a lethal event in that moment if there's not very much space between the moment when someone's thinking about suicide and when someone has access to means. Some of you mentioned this in the chat around military culture. What are some of the things that might get in the way of someone being willing to ask for help or to seek help? And whether that's seeking help with the VA or seeking help period at all. Some of that is a warrior culture or a warrior spirit around someone thinking that by asking for help, that means that they're being weak or that they're not doing their duty or standing up for what they need. The military is working on changing some of that culture and helping to make it easier for people to ask for help and to destigmatize asking for help during active duty, but culture is hard to change, and so are messages. And sometimes people who've been in the service for a long time carry those messages before around worried about losing their job, worried about losing their status, worried about being judged by other service members. Also, one of the things we hear from veterans is that when they come home, they don't want to share the stories of what they've been through, particularly if it's traumatic, with their families and loved ones. They're saying, my job was to protect you. I don't want to bring home things that are damaging or scary or upsetting to my family, I'd rather just push it down. And so in protecting family members, what they may not realize is that they're not giving themselves access to support. There may be stigma both from the external, stigma from other people. They may have heard negative comments about the service that they did or the particular events that they were a part of, or how they were deployed or where they went. They may also have self-stigma around seeking help themselves, thinking that having their own attitudes or beliefs around asking for help might make them be weak or not as much of a warrior or not doing what they need to. And we discussed before, these transitions from military to civilian life can be particularly challenging and are considered to be particularly risky times when we think about risk for suicide. I think it's really important to mention here, and some of you mentioned it actually in the chat, that we can't assume that all veterans are seeking care from the VA. And also that not seeking care from the VA may or may not be a statement about any of the quality of care at the VA. It can be that there are things that get in the way of someone being able to get care. One is that not all veterans are eligible for care from the VA.
My phone playing clear.
They may not have the right discharge type to be able to access care. The VA has specific discharge types. They also have length of service requirements. Now, all of this, it's actually fairly complex around what does eligibility look like around length of service, because you may have too short of a length of service, but if you have a Medal of Honor or if you served in certain campaigns, you may still have access. So if a veteran is telling you I'm not eligible for care, it's okay to understand that that might absolutely be the case, but also to ask if they would like any support in connecting with someone who could help them consider their eligibility. Also, this is important, there are priority groups for the VA around access. So not all veterans who are eligible for care, I am, for example, 30% service connected disabled with the VA, but not on one of the priority groups who's going to get access to care quickly. And so when we think about, what are those levels of care around priority, it could be around income levels, it could be around percentage service connection, it could be around time and distance from the VA service center. And so there are lots of reasons. The other thing could be choice. We've talked a little bit around past experiences or traumatic service history and saying, I don't want to be involved with the VA. I feel like the military was part of what the trauma was. Now I don't want to go and have the VA be providing the care. Could also be around wait times. The other thing I call it is the McDonald's effect. And what I mean by that is if you go to one VA or have a buddy or a friend who's gone to one VA and maybe didn't have a great experience about that, just like sometimes someone goes to a McDonald's, I go to McDonald's on Main Street, I have a poor experience. What I don't tell my friends and loved ones is that McDonald's on Main Street is bad. I might say all McDonald's is bad. And so the VA can also fall prey to that, where someone hears a news story about something going on in the VA, or they hear about something going on at a VA from another person, and they assume that that means all VAs are not great, or that they might not get good care. The important thing for this is to help inform people to ask whether they are accessing the VA or if they want information about it, to inform, but also to respect their choice. One of the key pieces that, and we actually talked about it in the chat a little bit, is around someone to call. So there is a national veterans crisis line. It is part of the 988 system. You call 988, you hit 1. To Brenda's point, it does go out, it can go to to call centers that are outside of Mississippi. So it's part of kind of the larger network. I think you may have some centers within Mississippi, but it definitely goes to call centers that are also outside of Mississippi. You can see the number of calls and chats have increased on a steady state over the course of the years. This shows you from 2021 to 2024. One of the things that's great about it is it has a very short wait time for callers, so they don't spend a lot of time on hold. Again, back to ambivalence. Now I want to shift over. I'm so excited about our guests here today. We have Dr. Adrienne Dorsey Kidd and Miss Melissa Lyles from the GV Sunny Montgomery VA here in Mississippi. And I'd love to have them share with you what sort of resources are available in your system of care. So welcome.
Hello, hello. Thank you so much, Allie. Great information being shared. Dr. Dorsey Kidd, she's also here, and we're excited to share the work that we do and some of the resources for everyone to add to their toolbox, and to see us as, an ally in the work that you all are already doing out in the community. As mentioned, my name is Melissa Lyles. I'm a licensed clinical social worker, as well as Dr. Adrienne Dorsey Kidd. We are both community engagement and partnership coordinators. Long titles, but we'll shorten it to CPCs for you all today. We can go to the next slide. All right, so what do we do? Long title, but what does that actually mean? So, our role includes coordination of strategies to increase awareness and adoption of suicide prevention best practices in the community. And we do this on all levels, including community, state, and regional. So, a quick little backstory at the VA, a lot of times people saw us as a silo. We stayed in, at the hospital. We weren't really outside the walls of the hospital. So, on a national level, they understood, hey, suicide is an issue that impacts everyone, and we would do a disservice to our veterans if we are not where they are. Half of our veterans don't even come to the VA for care, but we do care about our veterans, and we know that our veterans are at a higher risk for suicide. So we want to make sure that we meet them where they are, and we provide not only our veterans, but also the systems of care where our veterans are with the resources that they need to be able to help lower the numbers. So, with the work that we do, a lot of what we do is around coalition building. We do a lot of outreach and other things, which we'll get into in the next slide. So, what we do, Dr. Kidd, did you want to jump in here?
Good morning, everybody. And of course, Melissa, happy to jump in. One of the things that Melissa referenced earlier is that our role was basically created to meet the needs in the community. The statistics shows that a large percentage of the veterans that do not come to the VA for services are at a high risk of dying by suicide. And although the numbers with the latest annual report has showed some level of improvement in the community, it still is a staggering polarized differences in the number of veterans who come to the VA decreases the likelihood of dying suicide compared to the number of veterans who do not come to VA.
Do you mind if I throw those numbers out there? And I want to do this because we just had our new annual report released for the 2023 numbers. And for the veterans that are only served in community care, so that's outside the VA, for every 100,000, the rate was 70.6. For our veterans who received some level of care at the VA, but also community care, that number went down to 45.4. So definitely a decline. But also those who only receive care at the VA, their rate is 36.8. So there is a drastic difference between those who have no connection to the VA and those who do have a connection to the VA in their risk for suicide.
Thank you, Melissa. And so you hear the numbers and you see the differences, which is why our positions were created. And we've been in operation nationwide about 4 to 5 years, and we've been in operation in Mississippi about 3 years. There are three of us in the state of Mississippi, 2 in Jackson, and 1 on the coast. And I know they're hoping that they get a fourth one. They're slated for that fourth person. But part of our task is also to look at the 6 different levels of how we engage veterans in the community, and one of them is identifying service members, veterans, and their families. We have coalitions that Melissa and I have developed that CPC on the coast has developed, and we go across the state. Central Mississippi is, for the most part, our area, central to North Mississippi, but we go across the community, just connected with different agencies, different communities, different faith-based organizations, higher institutes of higher ed, what have you, and try to just connect in a way that we can decrease the numbers. But an example of our identifying service members would be coalitions that we have with the VFW. And we have about 3 or 4 different coalitions with VFW. And as people come there for socialization, for education and awareness, we have connected with some local VFWs, and our goal is helping them in identifying service members. They know it's a veteran-related organization, so they come there, but also in decreasing the number of suicide through education, through lethal means, just a number of things. Also, screening for suicide. We do this with coalitions as well. And one of the ways we do that is through Jackson State. We've developed a relationship with the School of Social Work, and we're training social workers as they're coming out, as they're preparing to graduate. And yes, they get all the tools for the next level in life, but a lot of times there's nothing specific to decreasing the number of suicide. So we're teaching them how to screen and hope that whatever agency that they go to, whatever community that they're involved in, that they would do screenings as well. We have done screenings at various faith-based communities when they've had like the Health Day and health fairs and resource fairs, and just teaching different people how to do screening. At our Spiritual Care Network coalition, which is comprised of a multiple coalitions, community-based stakeholders, we've also taught them how to screen for suicide. Promote connectedness. As Melissa shared, one of the things we see is that as veterans are to come back home, it's a real scary space those first couple months, trying to re-engage, trying to re-acclimate to life without the regiment of a military. And so through National Guard, through a variety of relationships, we've tried to connect with them and try to prepare them and provide support for them as they get back in society. One of the coalitions we have is Mississippi Alliance to End Suicide, and we do a lot of promote connectedness through support groups, just happen to do the preparation. Improve care transition. Melissa, you want to elaborate on what that is?
Yes, so improving care transitions. And I feel like this meeting in particular, this is, the work that you all are doing as well by, kind of closing those gaps. Because again, I talked about silos, but sometimes we're all kind of silos in doing the work that we do. We do so much, but we want to build a bridge to those systems of care throughout our state that can look a lot of different ways. But one of the coalitions that we have for improving care transitions, we work very closely with Hines Behavioral Health, which is our community mental health center. I see that some of them are on the call right now. That could include, going to MAP team meetings and, being a resource there. How can we plug in? They also oversee the CIT program for Hines County. So again, with law enforcement and CIT is crisis intervention training, with the CIT program, they're equipping law enforcement to be able to respond to crisis in the community, mental health crisis. So how can we be a part of that system of care? And, if there's a veteran in the community who wants to be connected to the VA, how can we build that relationship and that bridge? Also increasing secure storage. So we do a lot with lethal means training as well. I just mentioned CIT. Another thing that we do with CIT training, when we do presentations, we also make sure that they have gun locks and they know that we can get gun locks to their police precinct, so that, when they're out in the community and they might be responding to a call and it's someone who might be struggling with their mental health, they can secure their firearms in the community. So hopefully, as you were talking about, Allie, with those suicide rates, that can help mitigate that risk there as well. And lastly, safety planning. Safety planning has been proven through research to be a very useful tool in helping to lower risk. We have a coalition that Adrian just mentioned, the Spiritual Care Network. We've done trainings with them, which we really enjoyed, because at the table there are various faith-based agencies and congregations, but also there's mental health agencies, there's nonprofits, there's a variety of different entities that serve the community. And we were able to train all of them in how do you do a safety plan? What is a safety plan? And kind of going through the steps of what that is and the importance of that. So that is definitely a quick snapshot of some of the work that we do. I see Mr. McNear in the comments. He's from Region 9. We appreciate the partnership that we have with them. They do great work. We can go to the next slide.
Melissa,
Oh,
Melissa,
yes. I'm sorry.
I just want to go back and emphasize the lethal means safety, because she already mentioned that we are able to get gun locks to you as needed. We've had police departments to get gun locks because they know where the hot, as we would say, the hot areas are. They know where there are people who are having some mental health challenges that may be receiving outpatient care. They know where there's a, they get the call every Friday night when the drinking occurs and somebody's threatening to kill themselves or kill somebody else. And so we've been able to put guns in police department, gun locks in police department hands. And they're able to reach communities that we don't know anything about. And we feel strongly that that is decreasing the number of suicides as well as the number of homicides that occur in our various communities. One of the things that was interesting that Alice showed when she showed the initial statistic was 45% of the veterans own guns. And just in going around and talking to different people in the community, I'm shocked that the number is only 45%. I would have thought that the number was much higher because as we talk to veterans, I would say on average, the male veteran that I've spoken with own at least 4 guns, and female veterans own a minimum of 2 guns. So it's extremely relevant in every day in a lot of our communities, but definitely among service persons as well as law enforcement. And I just wanted to add that for that focus on lethal means safety. Just an example, one of our coalitions is a minister, is an African-American minister, and around Father's Day, he asked for gun locks, and he did a strong speech about violence in the community, self-harm as well as harming others. And he asked for the males in the group, in his congregation, to bear arms by taking gun locks around and just talking to people about decreasing violence, decreasing self-harm, and the whole gamut. And I think hearing it from somebody from their community was a little more relevant from them than hearing it from somebody coming from outside of their community. So we're using the resources that we have in extremely creative ways. And please reach out to us if you want gun locks, and if you have some, if you want just a standard, I'm going to give them out. But if you have some creative ways like that, we'd like to be a part of that and help you plan that. So I just wanted to do an emphasis on lethal means safety. That's all I have, Melissa.
Great points, Dr. Kidd. Thank you. Our program as a resource. So we're kind of wrapping up, but please, I know that they will be sending out these slides, but if we all probably have our phone right next to us. Feel free to take a picture of this slide. It has a lot of important information on it. It has both Dr. Kidd and I's contact information. And we already talked about what we do, but we feel that it's important to also emphasize a couple additional roles that are under suicide prevention that we work alongside our suicide prevention coordinators. So a lot of us on the call have probably heard of the Veteran Crisis Line. I saw in the chat someone actually mentioned the Veteran Crisis Line. So our suicide prevention coordinators, although it is a national line that a person would be connected to if they press 1, our suicide prevention coordinators follow up with those calls. So they are connected to someone on that warm line, but our suicide prevention coordinators follows up to make sure, do you have your mental health appointment scheduled? Do you have other needs in the home where, because we all know that suicide is a complicated issue. It is rare to never that it's only one thing that leads to someone contemplating suicide. So, maybe your lights are off. Maybe this is going on. They will talk to a licensed mental health professional here, one of our SPCs, and they'll connect them with those resources as well. And they also follow up on those high-risk veterans X amount of times to make sure that they feel supported. So they're kind of the safety net to our program. Also, we have our Compact Act coordinator, and Also, as you can see here, I have a flyer that talks about Compact Act, which is very important. So, one of the barriers to individuals, sometimes in the community, who may be, experiencing a suicide-related crisis is maybe they don't want to take an ambulance to go to the hospital. Compact Act was an act that was passed that pays for the transportation, emergency transportation, inpatient care, and some outpatient care of our veterans who have experienced emergent suicide crisis. So that actually has the contact information for our Compact Act coordinator who can talk more to that. So if you have questions about eligibility for that and what does that mean, Amani Elliott is great. And she knows all things Compact Act, but please see that as a resource as well. And if you haven't heard of the Veteran Crisis Line, please make sure that that's a number that you have saved in your phone. I think we have one more slide. Okay, yes, other VA resources. As much as I would like to think that everyone cares about suicide prevention and the work that we're doing, which I know you all do, I know that there's other programs here that people are very concerned about as well and are great resources to have. When we're out in the community doing outreach, most people are asking us about eligibility and enrollment, which that is not our wheelhouse, but we are social workers and we are bridges. So we always are open to connecting you to the appropriate person, but that is the contact information for them as well as benefits. We also work very closely with homeless services. The VA has a very robust housing and homeless service program, and the social workers in that program are great to work with. There's a strong correlation between suicide and suicide prevention work in homeless services. So, that's definitely an ally in the work that we do. And also community care. So you all are community providers. That's also, an area that I know a lot of individuals are interested in. But also mental health access. Please take a picture of that flyer that I have here, this resource guide. So, maybe you may not need suicide prevention, but we do have a very robust mental health program where we have, outpatient care, inpatient care, trauma recovery program, military sexual trauma program as well, a SUD, a substance abuse disorder program. We have a psychosocial rehabilitation and recovery center program. We have, individual therapy, groups, peer support, the list goes on. But a lot of times people don't know which door to enter first. So that kind of is a really short flow chart of how a person can access mental health services here at the VA.
Let me add, if I may, real quickly, another services that we have developed through suicide prevention here at the VA is our postvention program. And our postvention program, because I see a lot of mental health people on the call, our postvention program is designed for when somebody died by suicide, and when we as practitioners, as professionals have been caring for that person, have been providing services to that person. Of course, there's a need for it for the family, but ours is specifically for the people who've touched that person, whether it be the person who bring the food to them every day while they're hospitalized, the nurse that gives the medication, or the therapist that check on them on a weekly basis. And so if anybody would like us to share that with you, how you can emulate it in your agency, we'll be happy to do that as well. And that's just another resource that we have available by way of the VA.
That is so wonderful. Thank you both so much for coming and for being our guests and sharing these incredible resources. And I just love what you both said around, we want to get resources to veterans in the places where they live and work and connect, not necessarily that may be healthcare, but it also might be church. It might be, other communities and more informal networks. So thank you so much for the incredible work you do. And again, people will get these slides, so they'll have the links to the work that you're doing. And I love your idea around, take a quick photo of this so you know how to contact. So thank you both so much for what you do every day, and then also for being here with us.
Thank you.
All right. So as we move, we actually heard a little bit around some of these veteran-specific resources from our guest speakers. But wanted to share a little bit around if a person is able to get care from the VA, there are some things that you should know about it. One is that the VA is very specially trained in helping with trauma-informed care, with post-traumatic stress disorder, anxiety, behavioral health conditions, substance use disorder, aggressive and self-harming behavior, and psychotic spectrum disorders. And then from an access standpoint, a lot of people don't know this, that the VA actually has a more stringent access standards than community providers out in the community. And so, if someone is really needing something, they should be getting an initial screening evaluation within 24 hours or the next business day. And then they should be getting a more comprehensive training within 20 to 28 days. There's another piece that I think is helpful for you to know. And it's helpful for you to share if you've got someone who is eligible for care and maybe they're a little skeptical, or maybe they're not sure if they want to get their care from the VA, and that's this quality piece. And I just love the statistics that you both shared around, that veterans do a little bit better if they're getting their care either from a mix of community providers or from the VA. The VA actually did a huge push about 10 years ago and has been continuing to focus on it around evidence-based treatment and trauma-informed preparedness and trauma-informed approaches, as well as training their clinicians in military culture and addressing veteran-specific issues. And so from a satisfaction standpoint, nearly 80% of VA medical systems receive a 4- or 5-star rating with satisfaction. And by the way, in one of the listings around top VA hospitals in the country, your very own Biloxi, Mississippi Gulf Coast healthcare system was listed in the top 25. So if people get to care, they are getting great care and are highly satisfied with the care. There are lots of reasons that we've already talked about around why they either might not have access to it or might not make the choice to get that care, but wanted to give you a couple of things in your toolkit around that. So what we'd love for you to do in our interactive part is go ahead and put in the chat something that you didn't know that you learned today around a resource that's either national or in Mississippi, or conversely, if there's something that you'd like to see that isn't in Mississippi right now that you'd like to see. And if it is something that isn't here yet, but you'd like to see it, please note that in the chat. We'd love to hear from you and hear your voices in that way. Compact Act. Absolutely. That's a great resource. I'll tell you, I learned about what you all are doing with the gun storage and getting that into the hands. And I'm very excited about that work that you all are doing, because not only does that help with preventing veteran suicide, it also is around safety for law enforcement. Sometimes people try to have a suicide by cop by having a weapon that they would brandish or show. And so having safe storage is safe for the vet, for their families, and for our community. Postvention service, absolutely. And good postvention is great prevention too. Fantastic. One thing that I heard from someone in preparing for this work, yep, gun locks, fantastic, is the idea around what might it look like to have veteran peers. So the VA, in case you don't know, does employ peer support specialists, but what would it look like to have a veteran certification to be a certified veteran peer was an idea that I had heard that someone had asked me to make sure I mentioned today as something that might be a neat idea for the future. All right, great. Thank you so much for your interaction on that piece. So we wanted to spend a few minutes. Oops, I went one slide too many. And that is to talk a little bit around core components of offering support. So what are things you need to know around supporting veterans and their families, particularly when they're in crisis? So we have a little poll that we're going to put up. And this is, what do you think is the most important factor? You get to pick one choice in providing crisis support? Is it the level of distress that the person's in, current engagement with the VA, access to lethal means, veterans' preferences for support, protective factors, or something else? And if it's something else, would you be willing to write in the chat what something else is? Great. Thank you, Sataniel. Around DMH does train peer support specialists for the VA, not required, but many take the training. That's fantastic. All right, where are we at, Rachel, on our poll?
You're about 45%, so we'll leave it open for a little bit longer to get some more responses.
So I'll let y'all in on a little secret. All of these are important. There is no right or wrong answer. This is not a quiz. Oops. Okay. Great. So it looks like the single biggest answer was level of distress. And coming in second place was current engagement with the VA, and then veterans preference and protective factors, and access to lethal means was low, and we didn't have any something else's. So great. Thank you all for taking the time to take our poll. Let's talk a little bit around what some of the national best practices are around working together with vets. So one of the important things is really taking a trauma-informed approach. So ask, not assuming. Offer connection. We talked a little bit around this. Inform, give people resources and choices, but don't assume. Let's see if we can avoid any sort of a sense of value judgment around you really should, or you need to, or you have to, or the only way to get care is to do it this way. Choice is important, and autonomy is actually really important when we're talking around that warrior spirit and some of that culture with the VA. An idea that I wanted to share with you in case you haven't heard about it is buddy care. Buddy care is what I would call kind of the OG or the original peer support specialist, peer support work. And that is in military service. Often people have what is called buddy care, which is in the field or in the moment, someone who's going to provide in the moment first aid, or checking in on someone when you're not in a combat situation. It might mean calling, checking in on them, noticing that someone didn't show up to work, noticing that they seem to be having a hard time. So it's really looking out for one another. And so buddy care can also be super helpful as far as getting someone connected to, whether that's the Veterans Crisis Line or Veterans Resources or other support. Again, could be VA connected or not be VA connected. And so being able to leverage this important thing, even when you're talking with a vet or their family, to say, do they have a close buddy, or is there some, a trusted other who they get supported, who they get support to, can be one of those protective factors that someone may have and not even necessarily realize that it's a protective factor. And encouraging someone, a buddy who you're already connected with is somebody who, you can trust and kind of share some of those things. Promote safety. That doesn't just mean physical safety, but also that it's okay to talk about this. You're not going to shock me by things that you say. It's okay to have strong emotions in this conversation. Sometimes folks are worried that they're going to overwhelm providers that they talk to. Practice cultural competency, and that is cultural competency in every source of that, in every meaning of that word, which includes military cultural competency. If you don't understand an acronym, listening for context clues, we actually have a little acronym definition at the end of this presentation. Autonomy is so important. And helping people. The question might not be, do you want to get help, or I'm concerned about you from a safety perspective, but it might be, do you want to do this first or this first? being able to provide, just some choices so that someone feels like they're a partner, that you're partnering together with them and that not that you're taking control. When you think about post-traumatic stress disorder, avoiding sudden movements or loud noises, you often see veterans choosing to be in a place where they can see everything that's going on in the room or where their back's against a wall. And not sitting out in the middle of a room. We're all aware and sensitized to the fact that holidays where there are fireworks can be particularly triggering. And so having a support plan ahead of time, knowing that a holiday is coming up and saying, all right, what's going to be your plan for triggering times? And connect to evidence-based care, cognitive behavioral therapy, prolonged exposure therapy, EMDR, to be able to get people support and support that works. Because what we want is by the time when someone is willing to seek care, we want them to get care that helps so that they don't get to a place where they're feeling skeptical about care or not willing to seek care again because they're saying, I tried it and it didn't help. When the CDC Center for Preparedness Response in collaboration with SAMHSA's National Center for Trauma Informed Care actually developed a training that talks about these 6 components around trauma informed care and responding to community needs. And so I'll just quickly mention them. The source actually gives you access to the whole slide deck. So when you get these slides, if you want to click on it and you're able to see the full training, but the key components to keep in mind are safety. And again, all definitions of the word safety, trustworthiness and transparency, say what you're going to do what you say you're going to do, follow through. Trust is important. It also is that's an important key message in the military is that we do what we're going to say and we say what we're going to do. And so when you follow through, you build trust. Peer support, get connected to other folks, both peer supports who have behavioral health experience, but also veterans. Collaboration and mutuality. There is a hierarchy in the military, but there's also a very important piece around saying each one of us has an important job and we have an important role to play. And so even if you outrank me, I still bring something important to the table. And so when we can bring that through into the civilian space and in a crisis situation, saying, let's do this together, we can call together. We can do this, I'm a partner in your care. Those are important things, and that goes into empowerment and voice and choice. And then also definitely being aware of cultural, historical trauma and gender issues that may come into play and sensitivity. And so being sensitive to those things means that it doesn't create noise or extra barriers. We've talked quite a bit around reduction to lethal means. So the one thing that I wanted to say about this is that what is really important here, and I love this quote so much, I gave it some airtime here on the slide, which is that suicidal ideation can carry a lot of ambivalence. When we're able to put time and distance between the person and the access to the lethal means, that can be the difference between life and death. And so safe gun storage, asking the question, do you have weapons in your home? Do you have access to those weapons? Maybe what we want to do is store the bullets separately from the weapon. Maybe we want to go ahead and give somebody access to your guns. Does someone have a gun safe? Who has access to that? How can we create time and space between the time the person is feeling that they might want to take their life and the access to the means in which to do that? And so great work that you all are doing here in Mississippi around that. And again, getting those gun locks to law enforcement is brilliant. And then one other set of resources for you. And again, when you click on these things, they are hot links. Our Talk Saves Lives is a great program for, and they've actually created a tailored one called Supporting Veterans. Talk Saves Lives, supporting our veterans. So they have a 1-hour presentation available in person or virtually, and it's around how do you join veterans where they're at and be able to support them in ways that are that fit within the culture and connect with them in ways that maintain their autonomy. NAMI Homefront actually has so National Alliance for Mental Illness has programs that are created and a suite of resources specifically tailored to people who are either active duty or people who are involved with, who are a vet or involved with vets. And then I was excited to read about this. The Military Save Our Service Members Task Force advocated for National Guard members and their families to be eligible for TRICARE, and which you may not have known prior to that, was not something that they were eligible for. So, I think it's really around how do we remove barriers to access to care and to support. And the last thing that you'll see when you get these slides is some military acronym terms to know. There are other ones. Some of them are not safe for work, so I didn't include any of those. But this gives you just some ideas around, when someone is saying, hey, I served in, DOD, and, my XO was somebody who told me, who gave me this order. Now you can begin to understand, when I was in the military, our joke was we could have entire sentences that had no actual words in them. They were just all acronyms. The other thing you need to know is each service may use the acronyms a little bit differently. So PX or BX is a good example. The post exchange or the base exchange, those are different between whether you're in the Army, the Navy, the Air Force, Marines, National Guard. And just for fun, and Dr. Dorsey Kidd and Ms. Lyles know the VA has their own acronyms and they are not the same as the military ones. I had to learn that one. That was kind of fun to know. Great. Right? Like, and just as soon as one of, some of the acronyms, some of them change. So it's good to ask, it's okay to ask somebody what it means. What you do want to do is if they give you the answer, write it down so you don't have to keep asking over and over and again, because again, that shows, respect and listening and looking at those things. So really want to thank each and every one of you for coming to the training today and for your participation. And you'll be receiving a survey around satisfaction and what did you learn. And was it helpful and useful? If you're interested, please join us for the next monthly convening of Crisis System Partners. It is also on the topic of supporting veterans. And that is going to be on February the 25th at 10 a.m. We'd love to have you. You do need to register separately so that you have your own individual link. If you get a forwarded link, it ends up kicking you out and all those fun kinds of things. And there are trainings that have happened similar to this one that are part of the training library. And thank you, Brent. Brent is just a wonderful thing partnering with you all. There is a training library of trainings that have already occurred that you can come and learn about, even if you weren't able to be part of the live training. And so we really want to make sure that that you have access to those, and those are a living, breathing resource for you here in Mississippi. And available to you. And the last thing is, please spread the word. There's still a few more trainings and there's still more convenings. We love having you as a part of these trainings. We want to make sure that we get the word out so people know what resources are available to them. And of course, all of this is done as a partnership with Mississippi Department of Mental Health, and have just we enjoy working together in partnership with you to make sure that we've got great resources to folks. So yes, thank you, Rachel. In the chat, she put YouTube of past recordings, and you can see past trainings. So those are all available to you free of charge. And thank you so much. And we hope you have a wonderful day. And please take the time to complete the survey. We do read them and we do respond to your feedback. So thank you.